Good evening, and thank you for joining our second webinar, Recognizing Symptoms. I'm Cindy Gavin, Founding Executive Director of Let's Win Pancreatic Cancer. For those of you who are new to us, Let's Win is an online platform that enables doctors, scientists, and patients to share fast-breaking information on potentially life-saving pancreatic cancer treatments and clinical trials. We launched in 2016, and all stories are published on our site weekly, and they're available in both English and Spanish. And what is, I think, unique about Let's Win is that everything that we publish is medically vetted by a doctor or expert in their field. Before we begin, I want to take a moment to say thank you to our sponsor, AstraZeneca, and of course, our moderator, Erika Stallings, who is an advocate for BRCA and related cancers. And she's a dear friend and has been really, it's been great to work with her on these panels. And also, we're really, really pleased to welcome our two panelists, Dr. Valerie Antoine-Gustave and a pancreatic cancer survivor, Angella Dixon-Watson. Without further ado, I'd like to turn it over to Erika to kick off the presentation.
Well, first off, Cindy, thank you so much for those kind words. As Cindy mentioned, my name is Erika Stallings. I am a BRCA2 mutation carrier and an advocate for increasing awareness of racial disparities, particularly across the cancer landscape. So thanks so much to all of you who have joined us for the second part of our webinar series, which is focused on identifying and discussing symptoms of pancreatic cancer. So just to sort of set the stage for this evening, we'd actually like to start with a poll of the audience to test your knowledge of some of the common symptoms of pancreatic cancer. And one of the reasons why we are doing this, this webinar, as well as the series of webinars that we're doing, is because pancreatic cancer seems to be everywhere. The disease has recently taken the lives of several prominent Americans and Canadians, including Representative John Lewis, Supreme Court Justice Ruth Bader Ginsburg, and Jeopardy host Alex Trebek. Next slide. And what I wanted to do before we sort of get into the substantive discussion this evening is sort of just like set out the landscape of pancreatic cancer in the United States. Each year, about 60,000 people are diagnosed with pancreatic cancer. The average rate of occurrence in the United States is 12.9%. But as you see in the Black community, the rate of incidence occurrence is higher at 15.7%. The 5-year survival rate for pancreatic cancer is only about 10%. And part of the reason for that is because most individuals are diagnosed when the disease has progressed to a later stage. The most effective treatment for pancreatic cancer is surgical removal of the pancreas. But by the time that a majority of patients are diagnosed, it's at too advanced of a stage for surgical removal to be an effective treatment. And finally, one of the other reasons that the survival rate is so low is that at this time, we don't really have an easy screening test for pancreatic cancer the way that we have for example, that we have mammograms for breast cancer. So that makes it even more important to know what the symptoms of pancreatic cancer are, and also how to have conversations with your doctor about these symptoms. So let's take a look at the poll results. So clearly everyone who is attending this webinar this evening must have studied ahead because 91% of you responded that all of the above symptoms that were identified in the poll are symptoms of pancreatic cancer, which is correct. Pancreatic cancer has numerous symptoms, and some of these include, which I'll just walk through very quickly: pain in the abdomen or back, pain after eating, indigestion, nausea, loss of appetite, unintended weight loss, fatigue, dark urine, light colored stool, jaundice, newly onset diabetes, and depression. Now, I'm sure when you're looking at this list, you're probably thinking to yourself, all of these symptoms can indicate many different illnesses. And because the pancreas is located deep within the body, tumors are often not found during a physical exam. And these symptoms that you see here can mimic many other conditions. And as we'll hear from from Angella Dixon-Watson, who has gone through a pancreatic cancer diagnosis, many patients will say that after a pancreatic cancer diagnosis, they knew that something was wrong, but because the symptoms are so general, it was hard to get a definitive diagnosis. So that's why this evening we've put this webinar together, and joining us this evening to talk more about pancreatic cancer symptoms, we're joined by Dr. Valerie Antoine-Gustave, who is a gastroenterologist in New York City. She has a strong interest in diseases of the pancreas, and she serves as an attending physician at NYU Langone Medical Center, where she also teaches. She has a master's in public health, and her research includes a focus on health promotion and disease prevention. We're also very fortunate this evening to be joined by Angella Dixon-Watson, who is a 4-year-plus survivor of pancreatic cancer from the Baltimore, Washington metro area. And she has been sharing her experience with pancreatic cancer with church groups, as well as anyone who is willing to listen. So thank you so much to both of you for joining us this evening. And to start our discussion, I'm going to engage in some Q&A with Dr. Antoine-Gustave. Then I will have a discussion with Angella. And then finally, we will have an opportunity for a Q&A at the end. So as we go through the presentation, if you have any questions that you would like our expert panel to address, please just start to put those into the chat. And then we will leave about 10 to 15 minutes of this evening to address any questions that are raised. So with that being said, I'm so excited to be speaking with you, Dr. Antoine-Gustave. And one of the first questions I'd like to ask you is, let's just briefly go over the main symptoms of pancreatic cancer.
Wonderful. Thank you again for having me here. And I'm thrilled to be part of an effort to increase awareness about pancreatic cancer. But my goal here today is really to alert people to these very common symptoms and make sure that it's very clear that these symptoms should be investigated. So some of the symptoms that you initially mentioned, abdominal pain, for example, the way I see it is a lot of people come in with epigastric abdominal pain, which means above your belly button. And this can be very similar to symptoms seen when you have a stomach ache or you have acid reflux and you have what people call gastritis, which is inflammation of the lining of the stomach. So it's important to look at the symptoms in their totality. 71% of patients with pancreatic cancer do have abdominal pain, so it's an important one. Another symptom is indigestion. That happens in about 50 to 60%. And it's that symptom that you can't quite explain it. Like, you feel like things are not moving correctly. It imitates acid reflux. So you may feel full early. You may have just some discomfort after you eat. It's that vague symptom that sometimes we dismiss. And we think, well, it just happens sometimes. But it's also the recurrent symptoms and the consistency of it happening over and over again. It's not the one-off after having a lot of Chinese food or a fatty meal that we look at that. I think you mentioned the unintentional weight loss. That's actually a really concerning symptom. And I think we all have our antennas up when we're losing weight, but we don't intend to. So you're eating exactly the same meals, but you're losing weight. You're not exercising and you're losing weight. And some of the questions that you can get, it's like observations from your friends and family that are like, are you losing weight? Or you're noticing that your clothes are a little bit looser. And rarely do we see the severe weight loss called cachexia, where you're losing fat pads where normal people without severe weight loss would lose. Some of the challenging symptoms include fatigue. Many things cause fatigue. Anemia causes fatigue. But we have to look at it in context. Is it fatigue with abdominal pain, with indigestion, with weight loss? All of those symptoms together kind of makes us think that maybe something else is going on, and we can point to the pancreas. For us as gastroenterologists, anyone who comes in with jaundice, we're very concerned, especially if it's painless jaundice. So that means the yellowing of the skin. So the way you could potentially see it is your eyes are yellow, or inside of your mouth is yellow. And then if it's very severe, your skin is yellow as well. So the palm of your hands are yellow. That is very concerning because we think of three things. We think either liver, the bile ducts, or pancreas. And a hallmark of pancreas is, painless jaundice. So painless yellowing of your skin. And that is something that usually would end up presenting to the hospital, but in our clinics, we see it very often, and it can be very subtle jaundice. The other symptom I think that people don't talk about as much is back pain. Who doesn't have back pain is the question. But this back pain is quite different. It's not something that really responds to physical therapy, to Motrin, ibuprofen, and it's actually fairly common. About 50% of patients with pancreatic cancer present with this. And this is almost a kind of a radiating back pain. And that's something that we don't highlight as much. Other manifestations include are included with indigestion, nausea, loss of appetite. Those are kind of big ones that we see. And in practice, I remember the patients who come to me with particular symptoms that we've tried different treatments and they haven't gotten better. And that's an indication that we need more investigation. It's not an indication to give up and just accept the symptom.
Yeah, one thing I wanted to follow up on, you mentioned that with these symptoms, given that they're so common, it's really about the severity and the duration of these symptoms. And is there any sort of guidelines around this? You know, is it a week? Is it 2 weeks? Is it a month? That someone could use to say, hey, this is when I need to talk to someone.
Beautiful. That's a great question. Yes. Usually it's not a symptom that is a one-time symptom of about a week or even 2 weeks. It's something that ends up being intermittent. It may get worse over time. It may be it could start off as a couple of weeks and then you notice, oh, it's been a month. This is an issue. I should definitely go see someone. Arguably, if this is a debilitating symptom and it's changing your behavior. So for example, you stop eating because you're so uncomfortable with the indigestion, or the back pain, you're taking a lot of medicine for the back pain, and you're getting a lot of indigestion. Or if you've tried therapies, for example, people go over the counter and get Prilosec for indigestion, but you've tried that for a few weeks and you're not getting better, you should alert your physician. Something's going on. It doesn't have to be pancreatic cancer, but it needs to be investigated.
Thank you. And what are some of the other symptoms that we often see?
So this is where it gets tricky. There has been a high correlation of new onset diabetes, after 50, that has been attributed to pancreatic cancer. And usually it's less than 3 years of diabetes, and numerous studies have shown the correlation between diabetes and pancreatic cancer. So the risk of people with diabetes like a diabetic patient and those without diabetes to have pancreatic cancer is 2. So some people believe that diabetes may be a consequence. Well, actually, many believe it's a consequence of the pancreatic cancer. And it's just an early sign of pancreatic cancer. So I don't want everybody with diabetes to think that they have pancreatic cancer. But if you have diabetes and you have a lot of the other symptoms, like you have this abdominal pain that's not going away, or you have pain going to your back, you have a lot of indigestion that's not going away, you definitely need to investigate this. You can't just say it's just the diabetes. There are some people who get recurrent or new pancreatitis. Pancreatitis, as some of you may know, is inflammation of the pancreas, and there are many different causes. The more common causes are gallstones and alcohol causing pancreatitis, and that's very painful. And these patients show up to the hospital with like nausea, vomiting. But let's say someone comes to the hospital with pancreatitis, but they have no obvious risk factors that would put them at risk for getting pancreatitis. They weren't drinking. They didn't have any new medications. They didn't have gallstones. This is the person that I would be worried about. This is particularly true if it's an older person, because we know there's an association between older age and pancreatic cancer. And so these are the patients that I have seen in the hospital that I want to have them come back. I want further diagnostic information once the pancreatitis has improved. So anyone who has had that diagnosis, you definitely should follow up after your hospital stay with a gastroenterologist. Some of the other symptoms are blood clots that could happen. But we're not talking about just one blood clot, like multiple events of having blood clots. There are specific states that, such as Trousseau syndrome, in where you are just at increased risk of creating more blood clots. And this is quite a scary situation, but it is something that has been seen. The last, I would say, is a very hard one to talk about, which is sudden onset of depression. The best way I could say this would be, you have a family member or friend, and all of a sudden they have a change in how they are, and they are very depressed. You're not quite sure if it's, you don't see any link to something, an event occurring. This is a rare side effect of having pancreatic cancer, like symptom of pancreatic cancer, but it is something that we are seeing more and more, and we're paying attention to in the literature.
Thank you. And I think you've touched on this a little bit in some of the discussion of the symptoms, but I'm sure that in your practice, you see, many patients who have chronic indigestion or may have pain in their abdomen. So how do you determine the cause? And are there any particular signs that make you think, oh, this could be a pancreatic cancer diagnosis, or potentially a pancreatic cancer diagnosis?
Absolutely. This is what makes GI wonderful and challenging. People come in with indigestion, and some of the things that I would look at is the totality of them as a person. I have to look at them holistically. Do they have risk factors for pancreatic cancer? For example, smoking, obesity, diabetes. I'm looking at that person, and I will triage and think of them differently. Do they have significant signs associated with a chronic indigestion, like weight loss, jaundice? Definitely, I would be concerned about pancreatic cancer. But there are patients, for example, a patient that I met who, her symptom was that she had this epigastric pain and indigestion, and she was getting physical therapy for back pain. Very young, early 40s, and that's when you really, some of this has to do with the art of medicine and being concerned enough about a patient and their symptoms, because they had been ongoing for a long time. That's when imaging may be prompted. That's when looking to see if they have enough pancreatic enzymes in their stool may be prompted. Someone's always bloated. That's another big symptom of just bloating, not being able to properly process their foods, or having fatty stools, like stools that float. I always ask that question. I say, do your stools kind of sink to the bottom of the toilet, or do they always hover on top? And so these are some of the things that that clue me into, maybe this is something different and it involves the pancreas.
Thank you. And just one final question before we turn to Angela. Are there any of these numerous symptoms we've talked about, are there any that you see more often in your patients who end up with a pancreatic cancer diagnosis?
Yes, I would say among the top ones have to do with indigestion and abdominal pain and back pain. Like pain radiating to the back. So they kind of feel it in their stomach after they eat, but also heading to their back, and really just a lot of discomfort. And this discomfort can wake them up at night. When something is more serious is when they have the weight loss and the patient is pretty concerned, but the earlier pancreatic cancers, I would say those would be the more common symptoms that I've seen.
Thank you so much. And now I'd like to turn to Angella Dixon-Watson, who is so generous to be sharing her experience with pancreatic cancer with us this evening.
Okay.
So first off, I just want to start off our discussion. What symptoms were the ones that prompted you to go to a doctor?
Okay, the first symptom was itchy skin, and I clearly remember when that happened. It was the last weekend of April 2016. I went to a fundraising event in Wheaton, Maryland, and it was fun. It had great Caribbean food, reggae music, and Trinidadian soca music. And then the following week, I started feeling itching in the palms of my hand. And I said, I knew I had no allergies. So I wondered what was really going on, but I was not worried because in Jamaica, there's a saying that there's a myth that if your hands, if you feel your hands are itching you, that means you will be getting a monetary gift from somebody. So I wasn't worried at all, and I was excited. But then what happens? The itching continued, it graduated to my entire body, except my face. And the itching was so severe that I felt like I wanted to tear off my skin. In addition, there were blotches. I scratched so hard that there were blotches on my skin. So that it was one of the, and my husband said he heard me crying in bed saying, I can't sleep. So that was the first situation I had, symptom. And then after that was jaundice. I became extremely yellow, eyes yellow. Everything about me was yellow. And to the point whereby I was hesitant to be in the sun because my skin would actually be burned if I were to stay in the sun. And another thing that happened was a dark urine. And I was unsure what was going on. And that's one of the reasons I made an appointment to see my doctor. But the thing that frightened me most though was rapid weight loss. When I had my annual physical in March 2016, with my doctor, my weight was 164 pounds. And within in the month of May, it was significantly less. And, it was, and once my husband saw me in the hallway and he said, are you losing weight? Because it was that rapid. And I remember seeing my son, he was a bit concerned. He saw me, I saw him looking at me and I said to him, what's going on? And he said that he was just concerned that he was losing me because I had that gaunt look now and my eyes were sunken. So those are the things that really got my attention to go back to my doctor. And thank God she listened because that's a problem. Sometimes some doctors don't listen to you when you're saying that you're having all these problems. But she listened and she had me do the lab work, and also then she had other tests done. And then had an endoscopy, met with an gastroenterologist, had an endoscopy. And the endoscopy showed that it was cancer, but guess what? It was not pancreatic cancer. So I had all those symptoms, but it was not pancreatic cancer. And the doctor said it was duodenal. And he said it would have been easy fix because it had not penetrated my organs. However, we're talking, that was in the month of May. I had an endoscopy end of May, and a Whipple surgery was scheduled for June 30th. So between May 29 and June 30th, when the Whipple surgery was done, they discovered I had aggressive pancreatic cancer. It was already in my lymph nodes and it was already stage 2. So we are talking within 4 weeks from endoscopy to Whipple surgery. It was already in my lymph nodes and stage 2. And the doctor said, I would have had up to 6 months without treatment, but thank God, I'm here.
Well, that's an amazing story. And one of the things you talked about a lot of symptoms that you experienced. Mm-hmm. But just one question I have for you is, looking back on those months between before you got your diagnosis, was there anything else that you are looking back now and you're like, oh, that was going on and this was a sign that something was going on?
No, perfect health, because I had my annual physical March and I got a clean bill of health. And by last week of April, I started to have the itching in the palms of my hands. And then May was crazy. That's when I had endoscopy, all that stuff. So I had there were no early warning signals because, as I said, I had my annual physical in March and nothing was wrong with me.
Wow. You know, when you're looking back on your experience, and I know you share your story a lot and you're an advocate, is there anything that you want people to take away, you know, particularly people who may be high risk for having pancreatic cancer, to think about or look out for?
Bottom line, the onset of diabetes, because I did not have diabetes in March, but by the time I had, in May, I had sudden onset of diabetes. And also the jaundice, that was severe, and weight loss. If you are not dieting and then you are going through this weight loss, because I was said I was 164 pounds down to 127, not good. So that's what I would share with people. Don't just go to a doctor who listens, and then you'll be able to get some help.
Yeah. And with that, I'd actually like to bring Dr. Antoine-Gustave back up to our virtual stage. So piggybacking off of the question that I asked Angela is, you know, from your perspective, what are some of the things that an individual, so for example, I have a BRCA2 mutation, so I am at a higher risk for developing pancreatic cancer. So what are some of the things that I should be paying particular attention to or looking out for?
So before I start, I just want to say, thank you so much to Angela for that story, because I think she highlighted a lot of the symptoms I talked about, and how some of the symptoms that she had, she didn't piece together completely until she was losing a lot of weight and jaundice. So it's so important to hear the evolution of how that happened. But for those with highest risk factors, I think your case in particular, there are some centers that are actually more proactive in terms of imaging and diagnostic tests. And I'm not sure if this is what you're getting to, but in terms of diagnostics, many people start with you know, if someone's having abdominal pain, many of us have gotten a transabdominal ultrasound to see if there are any anatomical abnormalities in the area. The problem with ultrasound is it doesn't always see the entire pancreas, and it's not as good as some of the other imaging modalities that we have. And you know, so we have many others that include a CT scan of the abdomen. Many of us are familiar with that. And depending on the technique, you can see the pancreas really well to see if there's a structural problem. Angela was talking about the itching, and I didn't talk about that, and that was important. That happens when the tumor starts to obstruct an area where the bile can come out, and the bile ends up, you have a bile obstruction, which ends up causing the jaundice. So one of the early signs is itching, and then you eventually get the jaundice. And so CT scans can help you see some of that obstruction, as well as an MRI, a special one called an MRCP, which is a magnetic resonance cholangiopancreatography. So for short, it's MRCP, but this is a non-invasive way of looking at the pancreas, looking at all the ducts, making sure sometimes people just have an abnormality in the duct. And that's worth investigating and looking further with a gastroenterologist. So it may look simple. For example, the young patient that I talked to you about who was in her 40s, when we did imaging, she had a small cyst. That's it. There was no mass, there was a small cyst. But because she had pain in that cyst, I sent her for an EUS, And that bought her a lot of time. I sent her for a different test, which is an endoscopic ultrasound, to get a sample of that cyst because she was in pain, and she had been in pain for a long time. So these are things that really you shouldn't investigate on your own, and you should have your doctor be an advocate with you and listen to you. So for you, the most important thing is to pay attention to your symptoms, discuss them, alert your doctor. And then if you don't feel heard, you have to move on. There is no space for someone who does not listen to you. And that's probably the more important, listening to yourself, because you live in your body 100% of the time, and having someone who's on your side and is your advocate. I tell my patients, I'm on your side, we're a team. It's not you, it's not me, it's us. And so we have to work together until you're comfortable with the plan. And so that's kind of a long-winded way of answering your question, but do you have another question?
No, so you anticipated my next question. And so I guess, what I want to really hit home for everyone who's listening is that I think a common theme that we're seeing both from Dr. Antoine-Gustave and also from Angela's story, right, is the importance of a doctor who is listening to your symptoms, is being proactive about, investigating what these symptoms mean. And so I just wanted to add, as someone who's a patient myself, the importance of that, right? Like if your doctor is not listening to you, finding someone who is going to take those symptoms seriously, who is going to work with you to figure out the cause. I think that's just a really important message to stress. And that actually does lead into something that I wanted to make sure we talked about this evening, which, as you attendees may recall at the beginning of the presentation, I pointed out the fact that Black individuals do have a higher rate of occurrence for pancreatic cancer. So one thing I'd like to ask you about is, just talking a little bit more about these disparities and sort of maybe what the causes are.
Sure. Thank you so much. As a member of the Association of Black Gastroenterologists and Hepatologists, I'm acutely aware that, Black people are more likely to get pancreatic cancer than other racial groups and racial or ethnic groups. So some of the things that we haven't touched upon as much in this are risk factors. So smoking, obesity, diabetes, are just to name a few of some of the risk factors. When you have a society that already has health disparities, so people who are Black may have more of these risk factors, that increases your chance. So it's not surprising that there would be increased pancreatic cancer rates. So the important thing is that these are social issues rather than biology. So it's not that more Black people have genetic predisposition to pancreatic cancer. It has to do with some of these other social factors that can contribute. It's very hard. For example, I'm from the Caribbean. My parents are from the Caribbean. There was a certain diet that we had, and I've had in adulthood have to explore different ways of eating and what to have. We all know that smoking is a risk factor for a lot of cancers, but in particular pancreatic cancer. What makes the disparities difficult, and you have some of the stats up here, is that some patients present, Black patients in particular, with more advanced disease and disease that's inoperable. And I'm so happy for Angela. She told us her disease was at stage 2, and that was early. And that's kind of where we want to go, because you're more likely to undergo a surgical evaluation and surgery. So in this, we have a lot of work to do in terms of access to healthcare, doctors that pay attention to patients, in particular Black patients, and their symptoms, and not dismissing them. So I am happy to be part of that effort and increasing awareness, but it really has to go to the root of the problem, which are some of these social factors that we need to help address, like diet, access to good foods, smoking cessation, avoiding diabetes if possible. So those things.
Yeah, thank you so much. So what I like to do now, and just as a reminder, we will be having, or we're getting ready to transition into our question and answer period. So if you have any questions for our wonderful panelists, please put your questions into the chat. We will try to get to as many as possible. And so I'd like to bring Angela back to our virtual stage. And I guess one question I have, just to get started, is, we've talked a lot about symptoms and investigating and following up, but is there any type of screening test that patients can utilize for pancreatic cancer?
That's a great test. So unlike prostate cancer, unlike prostate cancer and colonoscopies, which I do, there isn't a definitive screening test. But people are looking at ways to indirectly assess the pancreas and without invasive procedures such as an endoscopic ultrasound. So some of the ways that sometimes I assess bloating, for example, is pancreatic elastase. If someone is not producing enough of this pancreatic enzyme, it may suggest that there's something that's causing the pancreas not to function as well. That could be chronic pancreatitis, that could be pancreatic insufficiency, but also pancreatic cancer. There is imaging that we have. We talked about the MRCP, but it's not really used as a screening. The best tool we have is the patient. You have to tell us the whole story. What has been happening? Like Ms. Dixon-Watson, you mentioned you were losing weight. That was a lot of weight, or let's say if it was weight loss and itching, we would want to investigate that further, do more tests. So I think this is the one situation where the screening starts with your symptoms, and then we use the best modalities that we have available to investigate for a possible mass. I do want to state that there are some studies that show that the lesions, the cells of pancreatic cancer have been found other places before they turn into a mass. So this is what makes it so difficult with pancreatic cancer, because by the time it is a mass, there's a big burden of disease oftentimes. And so this is something, the insidious symptoms are maybe the symptoms that you need to talk to us about early.
And that raises another question for me, which is, let's say, like Angela, you are noticing these symptoms. Who is actually the best person to have this conversation with, right? Is it your GP? Should you immediately seek out a specialist? Like, what's the best way to sort of start a course of action?
Question for me?
Well, I guess actually for both of you, I would actually, Angela, I'd love to hear how you acted on it. And then I'd love to hear from Dr. Antoine-Gustave just about how people should handle this generally.
Okay, what I did because I had my annual physical in March, and then within 3 weeks later, I'm having all this crazy stuff. I made an appointment to go back to my doctor. And then thank God, as I said before, she listened and she did not hesitate. She had things moving along quite quickly. And that is what I recommend, that, go back to your doctor. And if that person is not listening, as Dr. Gustave says, find somebody else. I was just blessed to have a doctor who listened to me. I've heard so many, there is a lady I spoke with. she was told she had indigestion. And for 1 year, she was told that. And then by the time they found cancer, it was too late. She could not have any treatment and she's no longer with us. So, you know, that you can talk to.
Yeah, I second that. I think if you have a good relationship with your primary care doctor, and it's just a new symptom, you should notify them. The majority of primary care doctors know when it is not in their wheelhouse and they need to refer. That is the case. And so I do trust a lot of my internists, my nurse practitioners to refer. However, if you have a gastroenterologist, you should notify them because they're not with you all the time. You are the one that may feel the more insidious symptoms of the fatigue and you just can't get out of bed. The indigestion's really ruining your quality of life. And if you're very concerned, you can ask, can there be an image? I mean, this is a conversation that you have with your doctor and say, you know, I'm really concerned, because sometimes they may not gauge your level of concern. And so you have to also be willing to be open.
Yeah. So one question I have, which this actually may be something we need to follow up on afterwards, is, I guess this is for you, Dr. Antoine-Gustave. Are you aware of any clinical trials for pancreatic cancer that have patient advocates as a part of the review team?
Review as in determining if this is an adequate clinical trial or if they can participate in a clinical trial.
I don't want to speak for the questioner, but I believe it's probably the former in terms of working as a patient advocate to be a part of the design of the clinical trial. So a part of the clinical trial team.
That is a great question. And I think that is something that clinical researchers would most likely be open to. I think when clinical research is designed and funded, there has to be some evidence, and some of the time that piece does not involve the patient advocate. But once the trial has started, that is the opportunity for people to get involved. Now, specific trials, I don't have an answer to that, but I'm happy if there's a way to get questions back. I am in New York. There are multiple amazing clinical centers, including NYU and Sloan and such, for that, where research is the key to getting some answers. I do see a question here, or maybe it's a statement about a patient who had 8 years of symptoms of undiagnosed pancreatitis with bloating and high BUN. I do want to address that question because I think pancreatitis is one of the things that people are just like, oh, well, you had inflammation of the pancreas and it just keeps on happening. I think this is one of those situations where you may have to see someone different if you're not being heard over the course of 8 years. And that may be someone that needs to look at you more holistically, that may be going to an academic center or going to a private practice, whichever. It just means that somehow you're not being heard, and you have an idea that something's wrong. The most important person is you.
Thank you for making sure we address that. You know, another question that I have, which again, for you, I guess actually for you, Dr. Antoine-Gustave, is there any ongoing research for pancreatic cancer such as there is for breast cancer?
The short answer is yes. There's tons of research, but there are different modes of research. So some of it is bench research on the actual pancreatic cells, how they are able to evade like detection. And then other research has to do with the clinical trials. So that has to do with either treatment or early detection, in particular, early detection in people with new onset diabetes. And seeing if that population should be a population to have more invasive testing early to see if they could be captured for pancreatic cancer. And that has gotten actually a lot of traction, but there are ongoing trials, yes.
I would also encourage the person who asked that question to check out the Let's Win website, which has provides ongoing information about research that is being done for pancreatic cancer. Our next question is, are there other parts of the body that could be itching apart from the hands as a symptom of pancreatic cancer?
Yes, I think Ms. Dixon-Watson's symptoms were more insidious in that she started off with the hands, but generally people have this horrible uncontrolled itching, and that has to do with the bilirubin being elevated past the level that it should be. So whether it's on your hands or soles of your feet, but most people it's everywhere, and they start feeling very uncomfortable and can't sleep. This is never normal, and you should always investigate it and get some blood tests because there are other conditions that do this. So it's not just pancreatic cancer, but it definitely needs to be investigated.
Great. And I just want to remind our attendees, we have about 5 more minutes for questions. So we have a really great panel. We have a really great panel, real wealth of knowledge. So if anyone has any further questions before we wrap up, I will say there was one in the chat that I don't necessarily, with that related to genetics, so I will ask it. If we are BRCA2, if an individual is BRCA2, what other genes, if any, should that individual be tested for?
I guess the question is, as it relates to, the question would be, is if it relates to pancreatic cancer, because as we know, you're at increased risk for pancreatic cancer. My inclination is to see a genetic counselor, because that's when we talk about family history and which tests would be most appropriate for you to undergo. There are families that have multiple genetic syndromes. And, I'm just thinking of like Lynch syndrome, Peutz-Jeghers. There are many other genetic syndromes, and I don't think that's why I myself am hesitant to do some of the genetic tests in my office. I have them for those patients who I know they won't follow up with someone else, and I just want them to get tested. But it's better to do it with a genetic counselor where they can really talk to you about the actual findings. And so that would be my short answer.
Yeah, and actually, Angela, one question I have for you is there anyone else in your family who's had a pancreatic cancer diagnosis?
No, I'm the only one. Mm-hmm.
And I want to address one more question, although I would also recommend that this person talk to a genetic counselor, which is patient with 3 sisters, one with breast cancer, one with stage 4 liver cancer, one with stage 4 pancreatic cancer. For their siblings, what tests should be done and or where do they start? I would just say as someone who's undergone genetic testing, given that family history, I would suggest probably starting with a genetic counselor, but I defer to Dr. Antoine-Gustave as I am not a medical professional.
Yes. One of the most important parts of history taking with a patient is family history. That is going to tell you what this person is at risk for. And so there are a few websites that talk about certain, that make a certain algorithm to see what kind of genetic tests you should go for. I'm talking about more specifically Lynch syndrome. But for me, when I see a strong family history of cancer, period, I want you to see a genetic counselor. And that's something that hits close to home for me personally, because there are strong family history of cancer in my family. So genetic counseling is something that I think is essential when someone has a high family history of cancers.
Yeah, thank you so much. And I think we have time for 2 more questions. So the first is, I am, sorry, I have to scroll back up. I am BRCA2 positive. My mother died at age 62 of, I hope I say this correctly,
Cholangiocarcinoma.
Okay, thank you. And I recently learned her father died in 1961 at 62, at the age of 62, of what the family described as stomach cancer. I am 71 and have been diagnosed with gastritis based on endoscopy with biopsy. I also go for an annual screening for pancreatic cancer at Columbia Presbyterian. How would I know the difference between my gastritis symptoms and pancreatic or bile duct cancer? I also get a lot of indigestion.
That is a great question. And I think you are not the one to know the difference. You're the one to amplify your symptoms to your doctor. And that really has to do, I'm glad that you get annual screening, and I'm assuming that includes the MRCP. So that actually really does look at the biliary tree where cholangiocarcinoma lives. That is basically cancer in the biliary, the bile ducts, okay? So you won't necessarily know the difference right away, but I think it's a combination of multiple symptoms. So not just the indigestion, but perhaps other symptoms that you're having, abdominal pain, back pain, that would alert your doctor. But I do feel comforted that you are already plugged in, and that you are getting one of a really high quality imaging modality, which is the MRCP, which is just an MRI looking very closely at all the ducts and in the bile ducts and the pancreatic ducts.
Yeah, and just finally, we have another question about genetic testing, and so which I kind of think we covered. So what I would encourage that person to do is there's a link in the chat to the National Society of Genetic Counselors website, which allows you to find a genetic counselor by zip code, and a genetic counselor can guide you through or have the conversation with you about whether you should undergo genetic testing based on family history. Dr. Antoine-Gustave, I don't know if you have anything you wanted to add to that.
No, I think there are a few centers, particularly in New York City, that do have genetic centers of excellence, and in most cities that have that. And so I would just inquire about those centers and see if you are eligible. It's a conversation. You don't have to do anything. You don't have to do a test just because you see a genetic counselor, but they can guide you to which tests to take. And that's a worthwhile conversation.
Well, I want to say, because we're close to 8 o'clock, so I want to first off thank you so much to both of you. Also, thank you to everyone who took an hour out of their evening to learn about these really important symptoms of pancreatic cancer. These symptoms are particularly important for individuals with known risk factors such as BRCA mutations or newly onset diabetes. For additional information about pancreatic cancer, please visit the Let's Win website. I know we also had some attendees in the chat who are asking how they can follow up. So please reach out to, the email address is info@letswinpc.org. You can use that as a starting point to reach out. And additionally, a recording of this webinar, as well as the links here to further reading and information, will be sent out to everyone who registered. So just thank you again to our panelists and again to our attendees.
Thank you, Erika. What a wonderful conversation. I know I learned a lot, and I really just enjoyed hearing from both of you. So, Erika, thank you for leading another incredible panel. And to our two amazing panelists, Dr. Antoine Gustave and Angela Dixon-Watson, we are super grateful for your time and your commitment to help educate the pancreatic cancer community and for sharing your story. Thank you all for being with us. We hope you'll be able to join us for our third webinar in the Let's Win series, April 29th, Finding Treatment Options. Thank you again, stay safe, and we hope to see you in a couple of weeks. Good night.